We're all sitting comfortably, hopefully. Good morning and welcome to the 10th meeting in 2014 of the Health and Sport Committee. As usual at this point, I would ask everyone in the room to switch off mobile phones and Blackberries in order we don't disturb the committee meeting. It should be noted, though, by people here that members and officials are using tablet devices, and this is instead of our hard copies of our papers. The first item on the agenda today is the decision on whether to take item 3 in private. Item 3 is to consider our approach to the Food Scotland Bill. Do I have the committee's agreement that we can take that item in private? Thank you. We now move to agenda item number 2, which is to return to our themes, work on health inequalities. The committee agreed that the next inquiry in this theme would be on early years, but before we start taking oral evidence on that next month, we have agreed to have a couple of sessions on access to services. And, of course, this morning we have a round table with a number of different representatives from varying organisations, and a welcome to you all. As usual at the round table, we just introduced ourselves, and I'm going to begin. My name is Duncan McNeill. I'm the MSP for Greenock and Inverclyde and convener of the Health and Sport Committee.
Emma Jackson from Glasgow Caledonian University and representing GramNet, Glasgow Refugee Asylum and Migration Research Network at Glasgow University.
Bob Doris, MSP for Glasgow and Vice-Convener of the Committee.
I'm Nina Murray, I'm Women's Policy Development Officer at Scottish Refugee Council.
Richard Simpson, MSP for Mid-Scotland and Fife.
Hannah McCulloch, Policy and Parliamentary Officer for Child Poverty Action Group.
Richard Lyle, MSP, Central Scotland.
Fiona Colley, Policy and Public Affairs Manager for Carer Scotland.
Colin Keir, MSP for Edinburgh Western.
Gil Patterson, MSP for Clydebank and Mulgai.
Pam Duncan, Policy Officer for the Independent Living in Scotland project.
Aileen MacLeod, MSP for the South of Scotland.
I'm Derek Young, I'm a Policy Officer with Age Scotland.
Rhoda Grant, Highlands and Islands MSP.
Lexi Parfitt, Campaigns Officer for SAMH, Scottish Association for Mental Health.
MSP for North East Scotland.
Thank you. Those formalities over. Now, I think we've got a first question from Gil Patterson, just to get us going.
Okay, thanks very much. Convener, I'm going to ask a fairly fundamental question. It's simply, what comes first? Is it health inequalities or is it poverty? And can we solve health inequalities without solving poverty?
Yes, please, Hannah.
Obviously, I think it's quite obvious that the relationship between poverty and health in the early years is extremely complex, and in some cases it's a cyclical relationship. Certainly, some part of the relationship between poverty and health is fairly direct, in that low incomes have a direct negative impact on health, such as dietary issues. There's quite a direct link between poverty and obesity, for instance. In other circumstances, the relationship is much more complex. Low poverty will cause stress in a household, which can impact on mental health for child and their cognitive development, which can reinforce poverty and ill health. At CPAG, we realise that increasing household income won't eradicate health inequalities, but it's unlikely that equalities can be meaningfully tackled until every family has an income that's sufficient to meet their most basic needs. So that would be where we would start. Increase household income. It won't solve the problem, but it's impossible to solve the problem without doing that.
No one else? That's it. Yep, and then Fiona.
Yeah, I would just like to make a point on that.
specifically in terms of mental health. I mean, we've known from sort of decades of research, as Hannah says, about the complex interaction between poverty and mental health. We know that poverty is both a cause of poor mental health, but can also be a symptom. We know that, for example, people with mental health problems are quite vulnerable to poverty and deprivation. If you're mentally unwell, it can be quite difficult to deal with bills and so on, making you more vulnerable. For some types of mental health problems, if you think about bipolar, for example, which is characterised by extreme highs followed by extreme lows. When you're in your high period, it's not uncommon for people to give money away, spend money left, right and centre, leaving you quite vulnerable. Also, if you're unwell with a mental health problem, you're not able to work, you're in the house a lot more, so maybe your fuel bills are higher, you're more likely to be dependent on welfare benefits. We've seen recently with all the changes to the welfare system that that's having an extreme impact on people's mental health. SAMH has just recently done a research report into how is the welfare reform impacting on mental health in Scotland, and we've found some very concerning things. So to come back to your original point about inequalities and access to services, we see that for a number of people with mental health problems who are living in poverty and deprivation, who are dependent on welfare reforms, their access to services is very it can be very difficult to access services at all if you don't have the income to get your bus fare to your appointment. Maybe if you live in a remote or rural area, you're only you need to get to a hospital appointment that's miles away. Public transport doesn't run very regularly in the winter. All these kinds of issues. If you can't afford to connect into your community, you might not be able to afford to go to your support service anymore. We've heard a number of our service users say that as a direct result of the welfare reforms and the reduction in their income, they can no longer afford to connect into the service that's supporting them. So that's a big worry for us. So in terms of which one do we tackle first, as Hannah's quite rightly pointed out, we can't do one without the other, really. We need to make a concerted effort to urgently tackle poverty and deprivation in Scotland, but we equally need to be making efforts to ensure that our services are well resourced, are across geographies, across different groups that have different needs. Both have to be tackled.
I think I would agree with the yes and no. For carers, obviously, levels of debt are very, very high. Carers are less likely to be working, they're more likely to be living in deprived areas, and that has a direct impact on their health. However, there are carers who are not in those situations, who do have access to adequate levels of finances. However, they face comparable difficulties in accessing support for their own health. They have comparable difficulties in supporting their own health, being able to access GP appointments, being able to attend hospital, for example. And that's about access to services and about availability of services. And that's where we see a very big gap, because if you tackle the lack of services, then more people, for example, more carers perhaps would be able to work. But the services as they are mean that many people cannot. And also, I think there's a group of perhaps older carers who may have access to more income, but they also have significant health problems of their own and have the same problems in accessing services.
Yes, I think there's a consistent theme emerging on this. That's partly true, but not the whole story. Certainly it's true that pensioner poverty is a problem in Scotland. There are 160,000 pensioners living in poverty today, and a further 100,000 on the edge of it. And things like, I think half of pensioner households are experiencing fuel poverty, so obviously energy bills are rising, and that's a significant concern for many older people. However, there are other challenges which we cannot and should not afford to ignore. There is an issue with the public perceptions of old age, so whether they feel that health professionals and allied health professionals understand what the particular needs and circumstances, not just in a sort of physical health sense, but also the social circumstances that older people face. Increasing use of technology in health contexts, which might exclude older people who are unfamiliar with it. And obviously, Lexi mentioned the whole question of rurality and physical, geographical isolation, and the sense of isolation and loneliness that many older people feel. That's not always related to poverty in quite the same way. That's something obviously Age Scotland have been campaigning on recently with the Still Waiting campaign, because community transport is very important where public transport options aren't up to scratch.
I think from our perspective, the two issues are very much intertwined. Working with refugees and asylum seekers, the vast majority of asylum seekers live in poverty in deprived areas, predominantly in Glasgow. Certainly the issue of accessibility of services, just the accessibility to bus fares and travelling to hospital appointments is a key issue. Asylum seekers are living on very minimal, where they do have support, living on very minimal levels of Home Office support, and in some instances we've recently carried out some research with pregnant women and around the accessibility of maternity services in Glasgow for them, and particularly pregnant women who've been refused asylum and maybe living on cashless support. Just being able to physically get to maternity appointments is a huge issue. Most women didn't know that they had any entitlement to support with getting to hospital for appointments. So we hear stories of people having to walk home after giving birth and things like that. So poverty really is a key issue for us. Our refugee integration research also showed a worsening self-identified health as people go through the asylum process, indicating that there are some links there between living in a marginalised situation, sort of in limbo, without the ability to work and access and sort of rebuild their lives, and that correlates with the worsening health that people are reporting. So definitely there are other issues, as others have said, but poverty is one of the key ones for us as well.
Anyone else? Pam.
Thank you. Firstly, thank you very much for inviting us to give evidence today. Appreciate that. One of the things that we said in our evidence is that disabled people experience health inequalities on kind of two accounts. One, on the fact that many of them are living in poverty, and two, on the fact that they are disabled and discrimination exists within access to health services across the piece. So it's a sort of intricate, multi-layered problem, I think, that disabled people face in terms of access and health inequalities. Disabled people, as we know, are hugely impacted by the welfare benefit reforms. Many of them are living in poverty, as I said, and fewer of them than non-disabled people are in work. So the issue of poverty for disabled people is big, and it is getting worse. And I would commend you to have a look at some of the papers that Inclusion Scotland have produced, particularly around welfare reform agenda, to give a kind of more of a flavour of that. The result of that is that many disabled people are having to make very difficult choices around food or heating, and in some cases social care, because as we know, and it wouldn't be an evidence session if I didn't mention the social care charges, that social care charges are increasing for disabled people at a time when they don't have funding to meet those increased costs. People are then choosing not to use social care services, and that isn't a choice that is something that is an easy thing to do, and it has a huge impact, because without having good social care services, we've seen across our evidence and the evidence from carers organisations the impact that lack of social care services have on people, and so that has a huge impact on disabled people's health in the long term. Many disabled people find it difficult to access mainstream transport. Buses are not always accessible. We don't know often where they're going to turn up and when they're going to turn up. And so that means that you're relying on often more expensive forms of transport. So despite the fact that there is a concessionary travel pass, many people still have to rely on things like taxis, and that's an expensive cost. And some people could argue that mobility allowance covers that, but I would quite make a strong case that mobility allowance is spent several times over. And so it's not often enough. So people have difficulty even just getting to appointments. And there are not often flexible systems such as phone appointments available to disabled people, either because it's not an accessible option for them or because surgeries don't often use them. So that's something that's a big issue. Isolation, of course, poverty can release to huge levels of isolation. That has a massive impact on health. And in fact is a huge, almost as big a concern as some of the main things we might ordinarily think of in health around cancer, for example. Disabled people find poverty as a huge barrier to their participation in sport and physical activity, which, as we know, has a huge link as well to increasing health outcomes. So that in itself is a big deal. And then Finally, and this is a kind of sidetrack to this, but I think it's an important issue to mention, poverty is a big issue, but so is funding for services, and I think we've kind of touched on that as well. So, for example, social care services are operating at high eligibility level criteria, which means prevention doesn't feature all that often. Peer support services are not being funded. These have a huge impact on isolation. They also help disabled people to often find solutions to some of the problems they might have. And then another example that we've heard about in terms of services specifically, and the example comes in the health service, is that communication support, for example, BSL or PAL and typists for hard of hearing people, are grossly underfunded and isn't something that people can afford easily to fund themselves. I mean, it can cost hundreds of pounds to have someone available for you to attend a doctor's appointment. And we know of an example of a woman who attended maternity appointments, and because she couldn't afford to have the support in place, and because the communication support wasn't put in place, when she was trying to lip read the doctor whilst they were scanning her, she was missing key. You know, the doctor would say, and that's the baby's whatever. She would look at the screen and miss it because there wasn't the right support. So these are crucial aspects. So poverty, yes, big issue, and funding as well for services.
I just wanted to make a point about transmission rates to do with health and sort of austerity measures, and there's been lots of evidence from Greece on the increased rate of transmission rates, particularly of things like HIV, over the last 2 years as a direct response to austerity and increased poverty in Greece. And so just really to raise that issue of transmission rates of illnesses such as HIV.
Gil?
Well, you know, Convener, I could ask, there's a question in every single answer, and it would be a specific question to each that would be different, if you follow what I mean. And that would mean I would be hogging the show. I think I'll reserve my right.
I mean, I think there was Bob maybe one in, but I think there was a number of issues that are common irrespective about issues like the isolation, exclusion, geography, distance from the service. I suppose we all accept, and I think when we are looking at inequalities, then the increasing poverty and the threat of further difficulties for that group or groups of people are all evidence with us. But there is an issue for us. What can we do in terms of dealing with some of the access problems that we have now, I suppose, is a challenge for us as a committee, and obviously an opportunity for people here, if we can communicate at least some of those issues that could be improved, mitigated, I suppose, is what we're looking for. Can this session actually put on the record some of the things that the government and their partners could be looking at to reduce some of these problems that people face? Is that a logical way to go? Fiona, thank you for that help in that.
Well, unsurprisingly, we have looked at some of the solutions. I mean, some of them are very complicated and are related to social care funding, and I think that the government needs to look very closely at how social care is funded, because it is so interlinked to how people get support. And from our perspective, where carers don't get support, we're talking about a third of carers get no support whatsoever, that people become ill. Even with support, carers become ill, but without adequate support, they're likely to become more ill. But in terms of practicalities, we know that the GP contract is going to include the requirement to keep a carers register, which is very welcome. But it needs to be a bit more than that. It's all very well to keep a register, but you actually need to do something with it. Now, what we would like to see is that the requirement is not just to keep a register, but to refer people on to support. And that may not be social care support. It may be community resources. It may be working with them to help in relation to their own mental and physical health. It could be looking at health checks. We know about 12% of carers are getting a health check, and most of that's through the Keep Well initiative. But there's an opportunity to enable carers to have an annual health check to make sure that they're not building up and storing up problems for the future within the current system with a bit more activity. There's already some good examples where local carers centres are working with hospitals and with GP practices on identifying carers and putting them in contact with the local carers centre, who can start building that package of support. And some of that is about things like reducing isolation, about speaking to other carers who are in the same situation. But there's also some practicalities within that. We know that, for example, if a carer becomes ill, and emergency services are contacted, there's not actually anything that says this person's a carer and we need to get things in place. And I believe that within the NHS 24 and patient records, there's an opportunity to do that. And we've had some discussions with the ambulance service about that, but they haven't necessarily gone far enough to make that practice throughout the country. And I think finally is about emergency planning. And it's absolutely critical when it comes to carers having the confidence that when they're unwell, that there's going to be backup for them. That if they need to go into hospital urgently, or even for routine operations or for routine support, that they know that there's a plan in place, what's going to happen. For example, you can have your operation that you desperately need. And we know, for example, of people who've turned down operations for knee replacements, who've turned down a treatment for very serious conditions because they don't think the support's going to be there. And I think that's a fairly easy thing to solve. It takes some time. It's one of the things that's mentioned in the proposed carers legislation is around emergency plan. And I think if we can really tighten that up, we can actually start to make a difference.
Una, you wanted to come in?
Thanks. I think, as you said, there are a lot of interlinking issues here, and for us, there are refugees and asylum seekers who are carers, who are living with disability, who are living with mental health issues, who are children living in poverty, and who are older. So for us, it really cuts across all of these different issues, and there's a lot of intersectional issues here. And one of the things that we've recommended is a strategic approach to tackling these issues, and an example of that is the new refugee integration strategy that we've mentioned in our submission, which is a really positive development from the Scottish Government that really pulls together all these different areas and how that impacts on refugee integration in Scotland. So I think that's to be commended. But a few other practical things I think that we've recommended could be done is, for one, thinking about the impact of the immigration bill currently going through Westminster on Scotland. Although a lot of these issues, particularly around poverty and the levels of support for asylum seekers and refugees, are reserved to Westminster and to the Home Office, there are policy areas that have a huge impact on refugees and asylum seekers in Scotland that are devolved to the Scottish Parliament, such as health, education, policing and others, and legal aid. So we really recommend that the committee consider the impact of the immigration bill in Scotland and the potential for increased statutory charging of migrants for access to healthcare. And there's already a lot of confusion around rights and entitlements to access healthcare right across the UK, in terms of people presenting to our offices, for instance, who've maybe been turned away erroneously from registration with a GP, who've been asked to pay for care. It doesn't happen that often. The legislation and guidance is clear in Scotland, but it does happen, and there are case studies that we can provide of where that's happened. So I think there's already confusion there, and people do move across the UK while they're in the asylum process, and I think we need to maybe think about that in Scotland and how that might impact. The other thing that we've raised in our written submission is around interpreting, and Emma and her team at Gramnet have also raised this issue. Interpreting, I think, is a key issue for access to healthcare for refugees, asylum seekers and other migrants whose first language is not English. And I think that's something that's been around as an issue for a very long time, and it really needs to be looked at a strategic level, I think. And the last thing we've already touched on is around destitution and people who are living in Scotland in destitution because they've maybe been refused asylum but are unable to return home for various reasons. And that's something that's been raised in the Scottish Parliament before. There was a debate in November last year around refugee destitution, asylum seeker destitution. And I think you know, something more needs to be done in Scotland to really pick up the pieces of those people that are perhaps at risk of street homelessness in Scotland. Although, you know, the support levels are a reserved issue, I think there's more that can be done in Scotland to really support those people who are here and while they remain here. So those are just a few things that we've recommended.
You want to come in at a point there?
I will come in. I have to say, Nina, as part of the question I was going to ask, you've kind of put on the record some of what my concerns were, but I did want to ask about the immigration bill. I should also point out that what you're saying in relation to the understanding within the medical professions over what migrants are and are not entitled to sometimes isn't as good as it should be. I've got an individual constituent convener who was taken off an organ transplant list because their application for asylum was turned down wrongly, and Glasgow and Clyde Health Board have pretty reasonably amended that, but there was a misunderstanding. So I can only imagine whether it's GPs, whether it's health boards, there can be there shouldn't be a grey area, but there can be a grey area over what migrants' rights are and access to services. And I just want to put on the record, Convener, that I think that does have to be clarified. What I would like to ask is whether you believe this is not just an issue for asylum seekers and refugees, whether it's a wider issue for black and minority ethnic communities more generally, because if you are a white person turning up at the GP surgery, they almost certainly won't assume that you might be an asylum seeker or refugee. So there's a whole series of questions they won't ask you. The same for hospitals, the same for in relation to the immigration bill, and how that impacts on Scotland with private landlords, where some of the most vulnerable people in Scotland will need to go to private landlords for accommodation. Many of those may be black and minority ethnic communities. Some of them may have previously been historically through the asylum system, and whether or not Scottish landlords are informed enough to know that the immigration bill's consequences hopefully doesn't apply in Scotland, and whether there could be unintended consequences there. So some comments on that. And finally, Convener, with your indulgence, I want to mop up this wider area in relation to hopefully issues with black and minority ethnics and with asylum seekers and refugees in relation to mental health and poverty and employability. If asylum seekers and refugees were able to work, many of them come with a significant skill set, which then goes downhill when they arrive here because they're not putting that skill set into action, and that makes them less employable once they do eventually get refugee status and leave to remain, and actually the impact that may have on their mental health through worklessness and the additional pressures that eventually puts on the Scottish NHS, where they access eventually those services, but their needs are much more complex. I know it's rather wide-ranging, Convener, but I think it's important that we get some of this on the records.
It is, Bob, and it's not the complete focus here, although there's obviously links and relevance there. But
I wanted just to say about, I mean, obviously I agree with many of the points you're making, but many of the immigration bill in the UK, I think clear guidance about what Scotland's going to decide about who's allowed access to services, because I think the creep of which is, as I put in the submission, is happening, and Scotland's, because migration on the level that we've had is so new to Scotland, we actually don't have to go through all these kind of processes and systems that has happened. We can learn from lots of other jurisdictions about the issues to do with migration, and if we decide that to have clear guidance about who is allowed access to services, and we give clear guidance, and you know, obviously from my perspective it should be everyone should have access, because the reasons why they're trying to reduce the evidence for the immigration bill around these issues around access to health for people who are from different directions is the evidence around that is very limited, and the ideas of tourist benefit tourists and health tourists and all this sort of thing. So there's very limited evidence about this, but the policies in England are being addressed. But I think Scotland has an opportunity to make its own stand about what it wants to do about this. But also the complexity, and I know you're talking about asylum seekers and refugees, but most of the migrants who come here are actually migrants who are here working, and it's really, and paying their taxes, and paying them at a higher rate, so they're able to access services and all these issues. And yes, I think there is a black and minority ethic, but actually many of the migrants who are here are white, and actually it's being cued on to do with language ability, it's being cued, there's lots of issues that, I mean, the complexity of it, the idea that that is then dealt with on the front of desk or front of services or at points of the moment that you're in crisis and you're at A&E or you're trying to access services, and that becomes the moment that you start discussing immigration status or access to health is you know, it just obviously doesn't make any sense to do that. And I think there's a moment in Scotland to think about this and to learn from all this, the evidence we have, because migration is so relatively new to our whole system, and I think that we don't have to find out in the way and create the experience some of the problems that other countries are experiencing with the
what evidence
delay.
Is there of, because I don't know whether other colleagues, but obviously Bob has came up with which is a big case of a transplant and whatever.
Yes,
I have never in 15 years had a situation where people have been refused, you know, or came to me and been refused A&E treatment because of their background. I haven't. Now, what is the extent of this? I mean, I think we've got to be careful. We're not sending out a message here that there's any. I mean, I'm not aware that there's going to be any replication. We have got a devolved health service, and most people around about this table believe in the ethos of the health service when people come. So I don't know whether what is the extent of this problem that we should be particularly concerned about, and the wider issue of access to health, which we've heard all the age, disability, class.
Yes.
You know, what is the? Who's suggesting that, or is there evidence that people have been turned away from A&E or hospital services?
I mean, there's not that I have evidence that people have been turned away except from A&E. It's evidence that people that it's problematic to go to A&E, and that the point of engaging with accident emergency services or trying to gain access to GPs, that there's delay, and the delay then impacts on what happens to do with their own care, so that it's harder to engage with the services. And this can be just because of front of house misunderstanding, the language issues, the anxiety about not understanding the service, but also because, and I tried to put this in and explain this in the submission, because of the signposting of where you should go for the sorts of services, that you don't understand who you're to go to in order to get the correct services, and so that again creates delay. Now that's a signposting, and as I say, that our system's been set up for people who generally understand the system, because migration is relatively new, and it's really just looking at the system as a huge system in itself and thinking, well, because migration is now something that happens in Scotland and into, as I say, to unprecedented levels, and that's something that's going to continue, that just to look at the system as someone who doesn't understand the system.
But this is a present problem.
Yes.
Of the present and the recent past. I mean, you know, so
but it's
yes, you know, it could be linked up with the immigration bill, but I mean, we've got, you know, we're in control of the health service, and if that's happening in the health service to the extent that's concerned to you and the people you represent, then it's guidance. It's about putting this situation right, you know, and providing those services, you know, sort of. Nina.
I think First and foremost, we need to really welcome the Scottish Government's approach and successive Scottish Government's approach to universal access and a human rights-based approach to healthcare. And you're right, the legislation is clear in Scotland, and also the guidance is quite clear on who should be charged and who should not be charged for access to healthcare in Scotland. But I think there's an issue of the rhetoric across the UK at the moment around the immigration bill and around public opinion around migration, immigration. There are differences in the charging regimes across the UK, and that can be very confusing for people. And I think quite often people are afraid to act. If you're in a very marginalised, vulnerable position, your immigration status is insecure, you could be afraid. And we've got examples of people who've been accessing, for example, maternity care very late on in their pregnancy because they're afraid of making contact with the authorities because of the perception, perhaps. It's more of a perception issue, that they'll be refused access or that they'll be somehow come into contact with the authorities, predominantly the Home Office, as a result. There are issues. We've got case studies of people who've been turned away from GP registration in Glasgow. Not very many. The vast majority are able to access, and they should all be able to access, refugees and asylum seekers healthcare. But there are instances where that awareness is not there among health professionals on the front line, and particularly gatekeeping staff right at the front line that are the ones that are making the decisions about who can and who can't access care. And I'm aware that we're hogging the topics. I don't want to go on, but I think it's something that we need to look at.
Can we move on to gatekeepers? Because I think maybe we'll have different experiences as gatekeepers. When I recently had a discussion with my disabled group, they find it very difficult sometimes to get past the receptions to get an appointment with the GP, and sometimes they feel that the GP's not got enough time because they've got communications problems. And does anybody want to speak to the gatekeepers or those people who phone up and look for an appointment? They say we can't have one. Derek, is one, Palm's another.
Yes, well, I alluded to this slightly earlier, but it's typical, for example, just a few examples. It's in many GP surgeries that they now have computerised booking systems for appointments. So if you're not able to have a face-to-face conversation with a member of reception staff, that may make it more difficult for you to articulate what your problems are. And if you're the type of person who isn't familiar with technology, you may feel you don't want to feel incompetent when you're presented with a computer terminal and you arrive at a doctor's surgery. So that's a very low-level but practical example. More serious ones are, for example, if there are older people who turn up at in open surgeries or at A&E, and it's very busy periods and they're not able to be seen quickly. Do they have the information that advises them how long it will take so that they can then factor that into the questions of how they physically got to the health centre? Because if they arrive by public transport, and obviously the National Concessionary Fare Scheme encourages older people to use public transport, and they do, if it's a busy period of an evening and they then aren't seen or discharged until the early hours of the morning, of course then there are no bus services running. So how are they able to get home? And I think if there was a more proactive sense amongst front of house staff, which considered what the potential needs of people might be based on their circumstances, that would be a very real example of the sort of preventative approach that obviously the Scottish Parliament and Scottish Government have endorsed based on the Christie Commission.
About the training of front of office staff to take account of, it would seem that if their awareness being presented with someone with a language problem or communications difficulty, and I know now, and I see regular notices in my local newspaper, they have training days, just like the bank, and they shut for a couple of days and all that sort of stuff. Does any of that training, I wonder, have you got some good examples of that, where people are being trained to deal with the different type of patients that might arrive there?
Well, one thing in relation to that, I would say is, that's a very pertinent question to ask NHS Education for Scotland, and I recommend you do that.
Yes, Derek.
What we are aware of, though, for example, is that the standards of care for older people in acute settings in hospitals are very functional at the moment. They are currently being reviewed by Healthcare Improvement Scotland, and we are very keen that they include things like patient experience, respect for dignity, communication standards, because that strongly impacts on your overall experience as a patient. Now, these are harder to inspect against than how quickly were you discharged, how quickly were you seen, sort of functional aspects. That's true. But if you are to improve our overall patient experience, if you put them in the standards, then they will be inspected against and reported against, and that will be an important way in which everyone can see how well particular health boards are doing in meeting that challenge.
Pam?
Thank you, Convener. I think there are various different issues in terms of gatekeeping for disabled people, and one of the issues that our colleague has just brought up there around kind of drop-ins and the sort of accessibility issues around that, and people being more aware of what might be an issue. So, for example, often family planning clinics and sexual health clinics can be drop-in clinics, and that's quite difficult for some disabled people to manage because of the transport issues, but also you're not sure if you need a personal assistant with you, you're not always sure how long you're going to be, and so it can be quite difficult to get that. The other thing to kind of follow from Derek's comments around accessibility, there was quite a lot of work done on accessible communication and inclusive communication that takes into consideration visual, hearing impairments, but also other communication impairments as well. And there's a toolkit that's been developed in co-production with disabled people with communication impairments and the improvement service. And I think that if that were to be something that was standardised and that people were encouraged in the front line in the health service, and in fact all through the health service to use, then that would take us a great distance towards addressing some of the access issues. The other issues around particularly gatekeeping as well and turning up at surgeries, very often rooms in hospitals or in doctor surgeries are not easily accessible to wheelchair users. So from my own personal experience, I've gone to several different appointments and I've not been able to be seen on the assessment bed, if that's the right word to use, because it doesn't move up and down and I just can't get on it. And so things like that I think are particularly pertinent, and I mean, obviously there would be a cost in replacing them, but I still think it's something that should be done. Around the issues of BSL that I spoke about earlier on, I think those kind of things are really important in terms of making sure that frontline staff are trained. And to pick up on the training issue, one of the things that we've said in our submission is that we think that frontline staff in the NHS and management should all be required to undertake disability equality training provided by disabled people themselves. And that, we think, is distinct from disability awareness training, which is more about awareness of particular impairments. That too is important, but disability equality training, we think, is something that should be considered. When disabled people who use personal assistance or social care go into hospital, if they're in for a certain period of time, sometimes 4 weeks, and it can depend on what the local authority contractual arrangements are, their support through self-directed support stops whilst they're in hospital. That in itself, if you've got personal assistants who've been around for a number of years, like myself, means that you can't just say to someone, we're not paying you now because I'm in hospital, and come back in 3 weeks when I'm out, because people need a salary, and so there's an issue there in terms of terms and conditions, and I think that that's a really important thing. I also think it could be quite innovative, because very often when people are disabled people are in hospital for an acute condition, or perhaps something to do with their longer term condition, they still need that kind of personal assistance support, stuff that nurses wouldn't ordinarily do for someone who was in hospital, if you know what I mean. So things that they would need whether they were ill or not. And that's something that personal assistants could do if they were allowed to support the person whilst they were in hospital as well. And I think that could kind of resolve both of those issues there. We think there's also broader issues in terms of addressing. So you asked for some solutions to some of the problems. We think that there's solutions that lie in housing, in terms of being able to get in and out your own house on a really basic level that can address issues of isolation. It can also address issues of delayed discharge, because if your house isn't accessible, then you're stuck in hospital, etc. And actually, with the health and social care integration, that's really, really important and a positive move. But housing isn't ordinarily or by default going to be considered there, and I think that's a huge issue. And we also think we note that lots of targeted approaches to improving health outcomes and addressing health inequalities are geographically based, but disabled people can often experience issues that are not necessarily geographical, although there are geographical issues. That people have, for example, I consider myself to have quite a lot in common with disabled people in Edinburgh, maybe more than non-disabled people in Glasgow where I live. So sometimes broader approaches, space-based approaches, don't often pick up on some of these deep-seated inequalities that exist. The apprenticeship scheme, I think, is one of those that we look at as being really successful in getting young people back into work, but it hasn't been quite as successful at getting disabled people into work. And so I think that targeted approaches for equality groups within broader interventions is going to be really important moving forward. And we suggest that good data collection, robust data collection, understanding who your people are within those areas or within those interventions is going to be really important in that, and also data sharing. I don't know how often I've gone to different appointments and people have not shared information about me, and to build on Fiona's point earlier about a kind of flagging up system where people just know that you will need certain supports. You know, I'll arrive somewhere and they'll say, the consultant room's upstairs, you know, just things like that we think could be really important. And finally, really quickly, co-production and working with disabled people can help us do that, because we can help people to kind of guess what the issues might be before they happen.
Well done, Pam, for getting the full policy in there. Lexi, please.
Yeah, I'd like to make a couple of points about gatekeepers and also potential solutions, but also just to take one step before that and look at in terms of access to service and access to the GP in the first place, about awareness levels of the services that are available. It was alluded to earlier about knowing which healthcare professional can help you. What are you entitled to in terms of support? How do you get to that source of support? We see that often, it cuts across all communities, the general public, particularly in deprived areas, also amongst people from BME communities, understanding who can help you and how do you get to that person. And there's a kind of broader issue within that, particularly around mental health, better understanding of mental health, and the people that can support you, where you get information about that. We often see that amongst certain communities, quite often people will only come into contact with mental health support services at a very late stage, where that might be at crisis point, that might be through another route, such as criminal justice, perhaps. For us, because access to service is such a huge priority for us, and we've been campaigning on this since early 2012, and looking at how do we make sure that people know about or have a better understanding of mental health, how do we support the promotion of good mental health and behaviours, and how do we get people to know about the healthcare that's out there that they can access. In terms of GPs, thinking of GPs as a gatekeeper, we've just done a big piece of research together with the Royal College of GPs in Scotland, which is not quite launched yet, but is referred to in my written submission, which finds that we know already that mental health, that around 30% of all GP appointments have a mental health component to them. The GPs at the deep end, which are the GPs in the 100 most deprived surgeries in Scotland, were asked about their kind of current concerns, particularly in the austerity context, and they said that their #1 concern was worsening mental health. But when we asked GPs about how able they felt to deal with the influx and increasing mental health issues that they were seeing in their surgeries, about 49% of GPs had said, well, we've actually not had any form of accredited training in mental health in over a year. That's quite a large number. Also, when we unpicked that a little bit and we asked GPs about what kind of referrals they were able to make and so on, GPs were coming back to us saying that, well, actually, I haven't referred in the last 3 months because waiting times are too long, or there's no such service in my area, or the referral criteria are unclear. So there's a number of pressures there on GPs as well, which there's something that we could be doing to help alleviate that pressure on them, supporting them better, and making sure that they're able to link up with other services that might be able to help support that individual. SAMH has been doing some work with the Alliance in terms of bringing in link workers into certain GP surgeries to provide that linkage between the GP, other services that may be able to support the individual, and trying to take a little bit of that pressure off, but also being a bit more innovative about how do we support people with mental health problems more broadly, particularly things around social prescribing and so on. So there's a number of things happening with that, but these types of solutions, while very effective and absolutely should be resourced and should be funded and should be brought forward, there's also the kind of broader structural issues around that, around how do we support people to have better mental health, how do we support people to know about their entitlements in terms of which types of healthcare professionals are out there and they can access, and then also how do we support those healthcare professionals to plug those individuals into the wider, broader support wherever they are, whether they come from a deprived community, whether they come from a BME community, whether they live in a rural area, whatever that might be.
Common themes there. Hannah, is that your hand up? Good.
Yes.
It must be getting painful there.
It was just to discuss the barriers that exist in accessing healthcare services for deprived families that don't exist for other families. Some of them are very practical. Families claiming job seekers allowance, for instance, you'll be aware that there's an increasing amount of conditions being placed on their claiming of that benefit, and a lot of constraints being put on their time in that sense, in terms of the amount of interviews they need to attend, the amount of job-related things, job-seeking-related things they need to do, and that increased conditionality and the threat of sanctions can really be restrictive in terms of the amount of resource and time a person can commit to their own health. I mean, we've had cases coming through our advice line of a father who was sanctioned 3 times in the space of 2 weeks because he kept missing interviews because he had to look after his child, and who was unwell. And the same is true of people in low-paid employment who may have to work extremely long hours in order to care for their family. People in low-paid jobs are also less likely to have the kind of flexibility and autonomy within the role that allows them to get away, to go to health appointments and that kind of thing. So I think there's a need for flexibility of services, to be reactive to those pressures, to consult with people in that situation, to ask how can we best tailor our services to make them accessible to you, and also to have health professionals working closely with families and be more reactive to what their needs are.
I mean, it's important to mention the wider aspects of employers and everything else. Richard, did you want to come in?
I wanted to switch slightly to issues that have been slightly raised already. That's the field of mental health, and the fact that people with mental health problems, particularly if they're severe and enduring mental illness problems, have poor physical health. And part of the inequalities in terms of life expectancy, which is one of the most glaring outcome examples, those with severe conditions or with learning disability also have poor physical health, and they die younger. So I just wonder about whether we're, given the system in primary care is becoming more proactive and less reactive. I mean, I think that's the shift that's occurring, but it's not there yet. Are we actually identifying these people and providing a combined care service that includes mental health, physical health, and social care, or are we still got these all split up into bits, and how much is that responsible for some of the inequalities that are around?
Any responses to that one? Oh, Lexi?
Just as you explicitly mentioned mental health, I mean, I completely agree. We know that from the deep end GPs and from the work that we've been doing, speaking to GPs, that, as you rightly say, in the most deprived areas of Scotland, GP appointments are characterised by multiple interconnected mental, physical and social issues. So there's absolutely a priority area there to be investigated. We also know that people in the most deprived areas develop multi-morbidity, so co-occurring complex long-term illnesses at about, I think it's around 10 years before the rest of the population. So you're absolutely right to raise that point, that kind of complexity and not seeing things in their individual kind of boxes as this is a mental health issue, this is a physical health issue, this is a social issue. In terms of, it comes back as well to the kind of purpose of this meeting and the original points about can we seriously tackle access to health services or inequality of access to health services without also looking at the broader structural issues of poverty and inequality, deprivation in Scotland and so on. So, I mean, part of the thinking behind the Link Worker programme that SAMH has been involved in with the Alliance is around looking at that, having somebody in a surgery who can, who an individual, when they first come into contact with their GP, can very early on be put into contact with somebody who has the knowledge of the local area, what's available and the types of services and supports that would be useful to that person. So, for example, if somebody's coming with a mental health problem, but they're also aware that there are financial or debt difficulties there's perhaps a physical issue, perhaps the individual's overweight and there's an exercise club they could be referred to, having a more holistic and sort of cross-issue understanding is one step towards addressing the points that you raise.
I wonder if there's any outcomes from that available yet. That programme is a...
I believe it's still very new at the moment, and it's in a limited number of GP surgeries, but we're absolutely going to be monitoring that because we believe it could definitely be something that once we've monitored the outcomes of those projects as they begin, once we've monitored what the outcomes are, is that we can push for that to be rolled out more widely.
Fiona and then Derek, we need to be conscious of time as we push on now. Pam?
I'll be really quick this time. Yes, I think that social and physical and mental health are still more split than I think they should be. Even although we're moving towards a more integrated service, and that's something that we welcome, and I hope it will improve that. We've always advocated for joined up policy making and joined up service delivery because I think it's sensible and it's needed. But we still have various systems operating within social care and healthcare, and neither of the two tend to talk to each other all that much. And we've also got the issue in social care where crisis intervention seems to be the focus because eligibility criteria raises, as I've said earlier, and social support is just not really featuring. And people are not getting that kind of support, which of course is essential to reduce isolation, and also it can help people's mental health, it can stop people becoming ill. So I think that's something we need to address pretty quickly. And then finally, we do still have two separate systems, one of which is universal and free at the point of delivery or need, and the other one is chargeable. And I think whilst those two systems exist, we're going to face a situation where health and social care will never quite be able to deliver the joined up provision that is needed.
I can't remember now. Fiona, I'll go for Fiona first. I can't remember what I called first, but Fiona and then Derek.
I actually want to echo what Pam says, that I think that the joined up system for carers in many cases just doesn't exist. Social care exists in one silo, health exists in another silo, and not only trying to cope with managing your own circumstances as a carer, but in many cases trying to manage the care and support of the individual. The systems are so complicated and so difficult for people to manage, and we talk about carers experiencing depression, stress and anxiety, and quite often caring does result in mental health problems, but a lot of carers, they say that the biggest stress they have is actually dealing with services and dealing with the bureaucracy between different services. And I think if we could do something to make things, and integration may help with that, to make things smoother, to make it a smoother journey for individuals, I think it would be very welcome. And just quickly, I wanted to mention about NHS Education Scotland. They are actually doing something around Equal Partners in Care, a programme about awareness of carers with health staff. And at the moment there's two levels of a more in-depth level for staff who are going to be very frontline with carers, and a more generic programme for all health staff. And I think it's really important, equally with not just disability awareness but disability-led training for staff to have a clearer understanding of what expectations there should be.
In response to Richard Simpson's question, I think the whole person approach is absolutely the right one to go for, because if we're to ever reach the goal of adequate prevention, then that has to be the aim. We mentioned gatekeepers before. If you're a GP, you will have training in geriatric medicine, so you will understand what the symptoms of particular conditions that affect older people are and how they should be treated. You will not necessarily instinctively have a feel for what social causes and the social consequences of those particular conditions are. Now, that's potentially where social care is to come in, but as Pam and others have mentioned, that's patchy and inconsistent. And also some harms or some social causes may be hard to spot. So mental health obviously is understood as a sort of harder to detect than physical symptoms. Equally, if older people are drinking alcohol to excess, for example, many of the understood consequences of that instability falling over are also associated with general issues of ageing. So sometimes it takes quite an acute sense to get an individual doctor to be able to spot what the social elements of particular health conditions are. We talked also about loneliness and isolation. That's actually an area where the third sector has a very good record. It excels in being able to connect people to their communities and offer activities locally. It isn't automatically going to be the case that doctors and surgeons will know what third sector services are available, and of course that's a picture that's changing, especially as there is uncertainty around the ending of the Change Fund.
I'm noting that ways forward for the Scottish Government and the NHS Board, many of these themes are familiar, aren't they? They might impact on different groups, maybe more seriously than others, but you know that about developing clear policies that highlight these things, and just picking up on Derek about the very personal approach to seeing people as individuals. I suppose you want to say anything about that?
Yes, I mean, I mean, I have a background in the NHS, and I think, and I've worked a lot with NES in my career, and I think my feeling about it is that much of this work around this issue is actually kind of done, but that it needs to be really clear, because I think, as Nina mentioned, the rhetoric and the broader issues around migration are so toxic that they sort of permeate society, and I think it becomes cloudy for people who then are dealing within the NHS or people who approach them, and so there can, I mean, it's difficult to work out how these issues kind of play out in reality, but there's been sort of a slight, sometimes there can be a feeling of sort of protecting our NHS, and sort of that people just need, if there's really clear guidance for people that this is, that the decisions that we've made on a high level about who's accessing it and how we want people to engage with our health service for all, is if that's just made clearer, that because, as I say, many of the policies are actually in place, but because of the dominance of a sort of the rhetoric around migration, particularly as is in the rest of the UK, is so anti-migration at the moment, that I think that would be an important and helpful thing to do, and not too difficult, I don't think.
Is it, you're looking at the other side of that, you know, we found that when we're looking at elderly care, that people feel difficulty challenged sometimes. The other perception of the NHS, which is, you know, we all talk about it in glowing terms, it's all wonderful, they're all angels, they're, you know, all of that. But for individuals, that's not always the experience, you know, the quality experience. Lots of these policies, and I've looked at personally, you know, how we treat older people when they arrive at a hospital and things like that, and we're not meeting the standards and the policies that are already there. Is that where we should be starting? Just to say, well, you've got all of these policies and you've got visionary statements and you've got, but we're actually looking at a delivery stage now to pick up on some of that.
Well, I think it is hard to, I mean, the policy, well, when I've worked in it, making some of the policies and helping to people want it to, you know, they've got the right ideas and they want it to happen, but actually implementing it. And I have worked with, you know, with staff on the ground, and, you know, that's really hard work making that happen. And, but I think one of the ways, and I think we put it in the submission, is to get the different parties together, so that we sort of understand. I think particularly around, because of migration is relatively new, it's not that there's nearly a sort of this long sort of bitter history of problems. It's just that actually this is something we as a country are now kind of engaging with, and to go into it in that way and to sort of approach it, that just to look at how the systems are functioning and to see how we can address it, assuming now we have people coming from lots of different directions who now live in Scotland, and just re-looking at how those policies which we have could perhaps be implemented.
Would the delivery of the policies we have be progress in terms of the inequalities that we've all described and the impact of those attitudes on individuals? Fiona?
Well, yes, but I think we have some really, really good policies, and I think if we actually got them working, we would be making great strides. I think one I particularly want to mention is around hospital discharge. There are hospital discharge policies within every board, and yet time and time again we hear it's not working, that people are discharged without adequate support, which then has a direct impact on the carer, but also has a direct impact on readmission. Pam earlier on mentioned housing and adaptations, these sort of things not being available. But we know there's a good policy there, but it's not being enacted. And I think part of the problem with that, and I think it's probably something that perhaps needs to be looked at about how different policies rub up against one another, and delayed discharge definitely rubs up against the hospital discharge policy, because what you want is good discharge. It's all very well to say we don't want someone to stay in hospital when they're physically well enough to be home, or they don't have a clinical need anymore. But if you're putting them into an environment where they're not secure, safe and healthy, the chances of them being readmitted are very, very high, so you're actually failing. So I think it's about looking how different policies interact as well.
My apologies, you've got on my list here and I haven't called you. And then Pam, I think, and then Derek.
Yeah, I mean, I think on your point about delivery of policies, definitely that, the delivery of the policies that exist, and I think to achieve that we do need a level of awareness raising and training. And when we were talking about, going back to what some people have been saying before about the sort of holistic approach and understanding what else is going on in people's lives, I think that's what we were talking about in our written submission around mitigating the impact of things like asylum, destitution, and it's about professionals who are working with people having that understanding of what else is going on in their lives, and the impact that that's having on their engagement with that person, and looking at the different options for, as Lexi was saying, referring out to community, community groups and services that can help people. But I do think we have to be aware, not to go on and on about the immigration bill, but we do have to be aware of the wider policy context at a UK level and the impact that can have on the delivery of policies here in Scotland. And it's something that we really strongly recommend that the Scottish Parliament looks at, is what the impact of that is going to be. It effectively puts in statutory law for landlords, health professionals to become de facto immigration officers, and that is a really frightening prospect, and something that will have an impact in Scotland, whether we want it to or not. So definitely delivery of the policies that we've got, but also being aware of those wider contexts that we're working in.
And then Derek.
In short, yes, I think that we do have some really, really good policies and legislation that we should, I think, probably go further in terms of promoting and making a reality. There are some things that I think also need to become duties. So there's lots of guidance around that I think are just too easily left to gather dust, to be quite honest. And I think that we do need to be looking a wee bit more about strengthening the hand a wee bit on some of those things, and I can be quite specific on that if we had more time. I also think it would be really important for us to look at broader policies, not just, so for example, not just looking at specific policies within the health service or NHS or even just within social care, but actually we have some really, really good policy on housing. We have, our Homes Fit for the 21st Century document is, it has quite a lot in there about adaptations and quite a bit in there about disabled people and independent living. That kind of stuff would be really good. And then, of course, there's the broader kind of UNCRPD stuff that I think we really need to look at and start asking about implementation and questioning ourselves on that. And Scotland will be examined on its progression towards UNCRPD at the end of the year, so that's a timely opportunity to do that. I think to help that happen, we need to work with disabled people's organisations so that we can help find the solutions to make it happen. Because most of the time, I don't think it's that people design things to keep us out of buildings, for example, although maybe it happens now and again. But I think often it's about just knowing how to make these things happen and how to implement the good intentions of current policy and legislation. And so working much closer with DPOs, and that includes disability equality training as well, will be essential, I think, in doing that.
Eric?
Certainly some of our policies and ambitions are robust and valuable, and if we could see effective implementation of them, that would be a success. So, for example, by 2016 we've got an ambition to eradicate fuel poverty in Scotland. I think that's a great ambition, but we're certainly not on track to meet it, and I think there's very little prospect that we are going to meet it. Partly that's because the challenges we're taking on in a policy context are tough. Partly it's also about money, and that's been raised before. We just passed in this Parliament self-directed support legislation that's coming into force in just a week's time. The ambition of choice and control, though, is not going to be realised if part of if some of the services that local authorities are providing they're increasing the charges for. Because you may have control over the cake, but if the cake's shrinking or each slice needs to be bigger, then that prevents a realisation of the policy. There are some changes we can make, and Audit Scotland, for example, have monitored recently a couple of aspects which I just highlight. One, in health and social care partnerships that are now being set up will be doing their strategic planning, formerly known as joint strategic commissioning. It's not immediately clear that they understand and have a common recognition of what health inequalities are, and how they plan to allocate the resources that they are being given by the Scottish Government to try and address those. So that's something that the committee can help to scrutinise. Secondly, not all strategies are inevitably going to be comprehensive, but equally well, which is the health inequality strategy we've had in place now for 5-6 years, doesn't specifically address the needs of older people and how inequalities affect them specifically. So that's something we'd want to see either reflected in a reinterpretation or revaluation of that strategy.
Colin?
Thanks, Convener. My question's actually relating to the difficulties that we have of people who are within the justice system in prison, and the fact that obviously there's got to be some degree of linkage. I know there's changes. The Scottish Prison Service are involved more with the NHS now, but perhaps someone could just elaborate as to the difficulties, if there's any personal experiences that you know of people who have come out the justice system out with, and the inequalities that access to services, all the rest of it, that you've found, and are any of the changes having effect, or will they have an effect, or do we have to go further?
I don't have answers to the question that you've asked, but I can say that obviously mental health and criminal justice are huge issues, and there's a strong linkage between mental health and people in the criminal justice system. There's also a lot of myths around it, that in fact people with mental health problems are far more likely to be victims of crime than to be perpetrators of crime. But SAMH is at the moment working on a piece of research around diversion, and diversion projects that are happening around Scotland, looking at ways of diverting people who are at risk of reoffending out of the prison system and into more meaningful and more helpful work. So it was just really to flag up that that's a piece of work that is happening, and obviously once that report is done, we'll be happy to share that.
Anyone else on that one? Nanette?
It was just in terms of the relation to delayed discharges from hospital. Is the main problem a sort of physical lack of carers, home carers on the ground, or is it the training of the carers that are already there, or is it a fairly equal combination of both?
It's probably a combination of both, but I think it's often it's a case that the service just isn't there at all, and someone is discharged from hospital to the person who cares for them, and there isn't a service there. And I think what's probably quite important to remember is a lot of carers are older. Over 100,000 carers are 65 and over, and quite a significant proportion are in their 80s. and 70s and 80s. And when you discharge someone from hospital in that situation, if there's no support, for example, to be able to lift someone, to be able to help them access the toilet, they may be physically, clinically well enough to leave hospital, but it doesn't mean they're well enough to live at home without support. So I think it's quite a difficult picture to say what exactly the problem is, but part of it is communication, to work with the family and say, what is it you need when you get home to make this work, and having that in place. But quite often these conversations don't happen. I mean, I've got a personal experience of that. My father was discharged from hospital. The first thing we knew about it was when he appeared at our house in a taxi in his pyjamas and dressing gown, and that was his discharge plan. And that's quite the extreme end, but it's actually not that unusual for someone to be told that morning that the person's been discharged and having nothing in place.
Respond to your question, Nanette.
Yeah, I think it's also because of lack of support, lack of services being available, and lack of funding for them. So people who perhaps are already in the social care system and then go into hospital, I said earlier on, they can often have their funding pulled back whilst they're in, which means that they then have to re-recruit or re-find another agency, for example, if they're using their agency, or find people within it that they've used before. And then, of course, there's people who go into hospital and come out now needing, in a way that they didn't before, social care services. And part of it is about communication, as Fiona's pointed out, and part of it is just about a severe lack of funding in social care services across Scotland.
Anyone else wish to respond to Nanette's? Yes, Derek.
A very brief point. Agree with both of those points. There also may be a need for adapted housing to enable you to be discharged depending on your circumstances. So that may necessitate a house move. So obviously that is a much more complex, and it has knock-on effects. So for example, you might have to then register with a new GP. And if you're the type of person who has multiple complex comorbidities, that could be a practical problem because GPs sometimes now require 2 forms of written address notification in order to allow you to register. Well, that may take a few weeks to obtain. If you're somebody over whom there is a continuing power of attorney, it may be that your attorney or guardian will receive all your mail. So the causes are complex and varied, and that's why a personal approach, which you have discussions with people, the co-production point that Pam mentioned before, is absolutely essential if you're to understand and then begin the process of saying, right, let's get these things in place so that we can have an effective and timely discharge.
Is it poorer people that's more likely to leave in that Friday situation or whatever, less assertive people? I mean, and the other side of that, who waits longest on our waiting list? Is it poorer people, excluded people? Is there any work been done on any of these issues? Nobody know?
There has actually. There's been some research showing that once you get to the GP and you're referred on, there isn't actually a discrimination at that point. There used to be, but there isn't now. That's improved considerably. Actually, it may be partly because of the QOF part of the contract, but that actually has improved it.
Bob, on that point?
It's quite not the QOF, I have to say, but more on the assertiveness of patients and their families and where inequalities could emerge from that. Now, I won't get into details of family experiences, but clearly, sitting on this committee, you're aware of what patients' rights are. So when family members are engaging with healthcare services and they're in hospitals, one of the key questions that you'll ask is, will we want to check the social care package is right before our family member is discharged? I suspect not a lot of families will necessarily ask that if they're less assertive, if there's some backgrounds where they're more likely to feel intimidated by the professional classes, if you like, and that kind of thing. So I'm just wondering if there's a need for patients and families to be more aware of what their rights and expectations are when they're engaging with services, because quite often in my experiences is hospital staff, for example, may not, and this is another issue of no joined up working, may not be aware that there's care issues at home because people don't like to admit that there's care issues at home. So individuals are discharged back into vulnerable environments without the nursing staff alerting social care staff that necessarily that's happened, and that's not best practice. And So it's just more any information you have about whether there's good practice in relation to informing patients and families of what their rights and expectations should be, and whether there's inequalities, how that can be addressed, I suppose.
Derek wants in on that. Pam wants in on it. Did you? And Hannah.
Well, other colleagues may have evidence of detailed research about that, but certainly anecdotally, we run what used to be the Scottish Telephone Helpline for older people, now the Silverline Scotland, and we do get, and it is family members that you identified, Vice-Convener, who are often coming to us because older people themselves don't want to complain, and they have a general demeanour that they feel that that's imposing on others, and we face that a lot. Equally, there are routes now, things like the Patient Opinion organisation and website, to try and vocalise many of these points. They are making innovative use of technology, but again, of course, technology is something that family members, if they're younger, might be more familiar and comfortable with. So we certainly do recognise many of the points that you've made about the general deference. Another one that comes across is that, and I think Pam mentioned this before, there are certain older people, and I don't know whether that's consistent with people in deprivation and poverty, who they will face an authority, and they will assume that if they have told one person within that authority, that the whole authority will understand their circumstances and know about it. Now that may reflect, which I think what your question is hinting at, somebody who doesn't have the experience of dealing with professional organisations to understand how they work and function and how they fail. So that may well be something that's worthy of further research, but there's certainly enough anecdotal evidence to suggest that you're onto something, but I can't back up with detailed data, unfortunately.
I think that's a really, really important point, and I would say that advocacy services are really crucial in that, to support people to understand what their rights are, and to therefore advocate for them, either themselves or with support to do that. But one of the issues I think that could be an issue is something that we hinted at earlier on, is around this stuff that is already out there, that, you know, good policies, good rights, good rhetoric, if you like, that aren't actually being implemented. And so that's something that I think we would need to get into as well, because you talk about the kind of patients' rights things, and actually people need to understand that they have rights. Well, there are some things that are also quite inconsistent in terms of rights. So, for example, we know we've got Article 19 of the UNCRPD, which gives disabled people a right to living in the community. But in reality, we know that the social care system's under pressure, that funding is so strapped for it that people aren't necessarily getting access to that support. So I think that whilst it's really important that we support people to understand their rights, we also need to look at some of the systems around and actually maybe strengthen them a little bit to make sure that those things that we think might be rights are actually entitlements, you know.
Anyone else in response to Bob? Hannah, sorry.
It was just, I'm aware of some programmes that try to target families that are least likely to get the most out of the health service due to a lack of awareness of what's available to them. There's something called the Family Nurse Programme partnership, where young first-time mothers are visited during pregnancy and in the first 2 years of their child's life. And it's not just about the health of the mother, it's also about wider well-being, sexual health, contraception, and even economic self-sufficiency, all the things that will improve long-term outcomes for the child. So there are examples of good practice out there.
I think I've got Fiona. Sorry, I was just going to go to the MSPs. I've got Gil and Richard that want to...
It was just very quickly to say that I would definitely agree that where people are more aware of their rights and are more assertive, that they can actually get things done. And I think that's a common complaint that from carers, that if they don't know something, that nobody tells them. And we've been working with MECOP and the Scottish Government on a Carers' Rights Charter and a set of accompanying standards, guidelines, whatever you want to call them, so that carers have these things up front and that they get them perhaps on their visit to the GP or their visit to the hospital. And I think, you know, I don't know what level people get copies of the Patient Rights Charter, for example. I know that I've visited hospital on a number of occasions recently. Nobody's ever mentioned it to me. Obviously, I'm aware of it, but it's not something that's very publicly available, and I think that that's maybe something that we need to change.
Nina?
very quickly, I would agree with what everyone's saying about awareness, the importance of awareness of services, and for refugees and asylum seekers, that's a huge issue. I was just by way of an example, facilitating a workshop on women's health with a group of refugee women, and none of them knew of the existence of the Sanderford Sexual Health Services, which is a widespread service right across the Greater Glasgow and Clyde Health Board area that's freely accessible to all, and none of them had ever heard of it. So that was just one example of how low the awareness is of services, and I think it's a really crucial issue, and leaflets are not, that's not enough. So the production of leaflets and translating them, that's helpful, but it's not enough to get the message out there that these services exist and how to access them.
Thanks for that. We're now approaching the end, but Gil Patterson and then Richard.
It follows on just from that last comment, but I go to the other end of the spectrum and the barriers to people presenting, and clearly people that have got low esteem, they have no confidence in themselves. There's a fatalism attached to it, and it's something that Lexi was saying earlier on in regard to people having complex conditions, but they don't present because they think that's their lot. And so, if we get in early, and I wonder if there's a way to get in early to, preventatively, so that although they may in their lifetime still have these illnesses, but not to the severity that it is. And I actually, I spoke about it just last week where my doctor is and where I go, and I can see it all around me when I go to the doctors, that people are so lacking in their own confidence, and so, they don't, they think that's their lot. So, I think it's a serious thing in deprived areas, and I wonder if there's been any work, or, what are we doing about it, or what should we do about it?
The man with the big questions, isn't he? Started us off with that. That was Lexi.
Yeah, I completely agree. There is definitely something in the points that have been previously made around, if you don't know that you're entitled to it, if you don't know it's your right, how would you know to ask for it or not to leave until it's been delivered? And as you alluded to there, in terms of mental health, for example, if you're suffering from severe depression, you already think that you're not worth helping, that you don't deserve to be helped, or however that may manifest itself. So the concept of going and insisting on being helped by your GP or by whoever that may be, it's a very difficult thing to do. You also probably don't feel that able to just get on the phone and call and find out, actually, can I get an appointment today? And if I can't, insist. You might not feel able to do that as a result of your illness. In terms of your question about what do we do about that, I completely agree that the early intervention and the sort of preventative agenda is absolutely key here. If we think about children and young people, for example, it's absolutely imperative that we are, wherever possible, promoting good mental health and well-being, helping young people understand. We spoke a little bit earlier about how physical and mental health are completely interlinked. And if you speak to teachers, for example, we've got the Curriculum for Excellence, which says that health and well-being outcomes are the responsibility of all practitioners. Yet, you'll find that the physical side is very well understood. How do you promote physical good health in young people? Well, you look at diet, you look at physical exercise. But then when you think about how do you promote mental well-being in children and young people, that is a bit less well understood. Well, a lot of the same things, physical exercise is excellent for your mental health, good diet is excellent for your mental health. So so there's something in there about better understanding of health, particularly mental health, and those interactions, supporting adults with a role in the lives of children and young people to do that, to be promoting those the good understanding of your health, positive behaviours that you can bring into adulthood around dealing with stresses of life, promoting good self-esteem, those kinds of things. There's something in there about just better understanding of mental health and well-being. And in terms of supporting people to ask for help, that's been a priority for SAMH from our Nowhere to Go campaign, which has been running over the last 2 years, which is all about making sure that people do know. We did a survey in 2012, a YouGov survey, which asked people, if you were experiencing problems with your mental health, could you name a source of support? And we were really shocked to find that 20% of people said they couldn't name a source of support that they would go to if they were experiencing a problem with their mental health. When we unpicked that a little bit, we found that that increased to over a quarter in the C2D social grade, and also was as high as 45% in people in the age group between 18 and 24 years. So there's absolutely something in there about that understanding of there are services there that can help you. You are entitled to access them. There's obligations around making sure that whatever's happening in that service means that it's accessible to you, whether that's translation or whatever that issue might be. So yeah, I'm really glad you raised it, because it's absolutely a job of work to make sure that people are able to go in and to ask for the help and information and support that they're entitled to have.
Anyone else? You want to come in on that, do you?
Well, it was just, I wanted to just, I think part of the reason I was invited to come here today was about interpreting, because of the work that we've done in this project, which was looking at, because of the policies exist around access to health, and then looking at how people were still experiencing difficulties, and just it's unclear. Obviously, there's a cost to interpreting services, and at the minute health boards are making decisions around how best to organise interpreting services. But I think one of the things that we noticed from our work is that there is very little education of staff about interpreting and how to engage with interpreters, and so and not having an interpreter has quite an impact on how people access their future, the health and that services at that moment, but also their understanding and the knock-on effect on delay, misdiagnosis and confusion around those issues for their future health. And really, I just wanted to say that when you're looking at things that could be done, there is, we have created an education tool which can be accessed, and again, and is free. It's developed and able to roll this sort of thing out across health, for health specialists and for interpreters in Scotland, about engaging with this issue of interpreting in health care situations.
Thanks for that. Anyone else? Hannah?
Just to get one in. Really, it's not directly relevant to the question, but it's just, there's a lot of talk about prevention of health inequalities, and I think it's just important to keep considering the fact that in the next 6 years there'll be an increase in the number of children living in poverty in Scotland by up to 100,000, and it goes right back to the very first question about what comes first, poverty or ill health. I think it's important to keep our eye on the ball in terms of maximising income for families that are at risk of falling into poverty, and that there's great examples of health services being involved in that. Healthier, Wealthier Children, for instance, in Glasgow is a partnership between NHS, Greater Glasgow and Clyde, Glasgow City Council and a range of other councils now actually, and Glasgow Centre for Population and Health, and that involves frontline workers during the first stages of a child's life, referring families that they think may be at risk of financial difficulties to income maximisation services, and it's proved a huge success. And I think within the first phase there were 2,500 families referred for advice, and that increased the income of those families overall by £2.5 million. So there's a huge amount of work to be done there in terms of future-proofing against increases in poverty.
Yes, Derek, and then I'm quickly going to go to Aileen and then Richard.
Just very briefly in response to Mr Patterson's point, I think this is to do with the reinforcing cycle of poor mental and poor physical health. So in areas that are more deprived, you find more evidence of unhealthy lifestyles being led. So poorer diet, less physical exercise, more intake of alcohol and tobacco, all of which we know are key drivers of poor health. these reinforce levels of depression and anxiety, and for older people, if they feel socially isolated, those are big causes of feeling depressed and anxious. And so if that is your experience within your local community, that is what you will understand to be normal. So I don't know how we can unpick all that, but it's certainly something that you're onto, in that there is a reinforcing cycle of many of these elements and aspects. And telling people about their rights may be one aspect of it, but there is a broader question of demonstrating to them in a real sense that they can understand and feel in their daily lives that they can live more positive, have a more positive attitude towards their health, they can undertake more exercise, they can improve their diet, they can cut down on alcohol and tobacco, and all of that will then help to generate more of the positive mental health outcomes, and more perhaps of the assertiveness about what they feel that they are entitled to and might expect.
Aileen?
Thanks very much, Convener. And obviously this morning we've been had a good discussion around, looking at the various ways in which we can sort of try to break down barriers and helping people to access health services and the support they need. And obviously what we don't want to be doing is to see more barriers going up. So I was quite interested in people's views around the importance of the benefits of universal service provision, such as in terms of like with free prescriptions or in the free eye tests. Because obviously there was the Prescription Charges Coalition in England, which brings together more than 30 health charities and organisations that support people with long-term conditions. And they published a new report the other week that stated that over a third of people that they questioned had reported that the cost of their medication had prevented them from taking it as prescribed. And obviously, we've got a commitment from the Scottish Government to protect free prescriptions. But I just wanted to know that, views from around the table this morning, just in terms of, how you see the importance of universal service provision, and whether you think that they, go some way towards helping us to narrow health inequalities in Scotland.
Eric?
I'm conscious I've spoken several times, Convener, but the debate around universal or targeted benefits and services does often revolve around older people, because they are oftentimes the beneficiaries of them. Certainly one thing we've seen, when you look at, for example, the basic state pension, that has fallen from 25% of average earnings down to 16% in the last 30 years. Now, there are targeted benefits on top of that in terms of pension credit, but the main problem for older people is that there's a massive problem of underclaiming of this. And that may be because people don't know that they're entitled to it, they don't feel that they want to ask for help. There's a disincentive effect in the sense that they feel that basic provision was part of a bargain that they made through paying their national insurance contributions over many years. So, as a result, pension credit actually is not a very robust indicator of who amongst the older population is actually poor and deprived and not. And that has knock-on effects for all kinds of public policy in terms of measurement. And certainly the National Concessionary Fare Scheme, for example, which is a universal benefit, that has encouraged people of all social classes to use public transport. And it has had wider ranging knock-on effects. So there's a study in England of their scheme, which is broadly similar, which suggests that because public transport encourages you to walk, from wherever your starting point, your destination is, to the bus stop, it encourages more walking, greater levels of fitness and more active travel generally. It also encourages you to meet and talk to other people who are using public transport in your community. So there are positive, virtuous circle effects of universal provision, which, albeit is expensive, shouldn't be underestimated, and some of it is very difficult to measure, but it's certainly present.
Fiona?
We should feel generally positive about universal services. I think we know that carers have significant challenges on their finances. We know that many of them are in debt. We know that many more, nearly 60%, are in fuel poverty. These are not just carers who are on the lowest incomes, because I think the thing that's important when you have illness and disability within a household, that income is not the same as disposable income. And once you factor in the costs of disability, such as extra heating, special diets, care costs, etc., etc., what people have left may be very, very little. And if they then have to pay a prescription charge or an eye test on top of that, it might make it unmanageable. So I think that's generally why we feel quite positive about it, because I think when you target things at very lowest incomes, which is laudable in many respects, sometimes you forget that people who are living on the very margins because of the circumstances that they're in, and what Derek was saying, that the measure of pension credit doesn't necessarily find out how many pensioners are really in poverty. And I think the similar thing is with carers and disabled people.
Anna?
Just to say that as an organisation we're really in favour of universalism, and it's not purely because it means that anybody can access the benefit, that people on higher incomes can access the benefit, whatever that may be, the service, whatever that may be. But people on the lowest incomes, people most in need of that service, are far more likely to be able to access it if it's universal to everybody, partly because of the lack of complexity. You don't need to understand exactly whether you're eligible or not. It's not expensive to have to work out whether people are eligible or not. And also, increasingly, the amount of stigma attached to living in poverty or claiming benefits really puts people off, especially young people who have a lack of confidence about these things off. So it's something that we're really in favour of, and whether it's child benefit or free school meals or health-related benefits.
Else? Pam, sorry.
No, it's okay, thank you. I would echo much of what's already been said, particularly in terms of the extra cost of living as a disabled person. I think the most recent research that I can think of off the top of my head came from Leonard Cheshire, and it was around, it found that I think the increased costs of living as a disabled person or having a disabled person in the household are about 25% more than not, so very much in line with what Fiona and Hannah have said. But it would be remiss of me not to miss this opportunity to also mention that these are also about choices, and universal services are fundamental about choices. And one of the things that we from the disabled people's movement and organisations would say is that we find it odd that social care is not also considered something that should be universally provided, particularly given its absolute essentialness, if that's even a word, to the equality and human rights of those who use it, or of the carers of families of those who use it as well. And so I think it would be really important for us to consider that along the lines that social care is an absolute key infrastructure for the equality and human rights of disabled people, users of it, and carers and their families.
Thanks for that. Rhoda? Have I got still good, Richard?
Everybody, I think, in opening talked about transport as one of the barriers to health for various reasons. I cover the Highlands and Islands, which is kind of a very rural area where things like you may have a bus pass, but you can't actually use it because there's not a bus. How much does that exacerbate the problems, the barriers that people face with transport if you live somewhere where there is no good public transport?
Comments? Pam?
Really briefly, I would echo just pretty much what we said in our written submission. Rhoda, I think that's a really, really important point. Many disabled people find transport a huge issue, not just that there may not be transport, for example, in rural areas, but even where there is, it might not be accessible for disabled people to use. And as I said earlier on, people might assume that Mobility Alliance can in some way go towards that, or the concessionary bus pass can in some way go towards addressing the issue, but it generally doesn't, because actually the cost of using accessible transport, for example, is often taxis for some disabled people, can be prohibitive in terms of attending healthcare appointments. So I think transport is absolutely essential.
Anyone else? Derek?
Unsurprisingly, since this has been a key focus of Age Scotland's campaigning work over the last year, I agree. We weren't able, unfortunately, at least not yet, to persuade the Scottish Government and in the Infrastructure Committee that our proposal to extend the concessionary fare scheme to community transport was the right approach. But our broader ambition is to say that community transport is an essential backup to public provision. especially in remote and rural areas, and that we have to have a sustainable future for funding it. And there's been some work done. There's £1 million spent on a new minibus fund, all of which is welcome, but we need to achieve an overall ambition of a sustainable future for community transport to provide that additional support where public transport provision just isn't enough to meet the needs of people.
Highlight that, as I mentioned before, transport for it's not really relevant to rural areas, but even it's even where there is excellent public transport in the cities, for people we work with, transport is a huge issue and a huge barrier to them accessing the healthcare that they're entitled to. Many people. Many, I mean, not relatively many, but in the hundreds of people living in Glasgow are living without access to any cash at all. People in the asylum process who are towards the end of the asylum process, and that is a barrier to everything. You have to walk to the shop, you have to walk to sign on at the Home Office, you might have to walk to get to your lawyer's appointment. So it's a really huge issue, and accessing healthcare in particular. When in our maternity research, none of the women we spoke to were aware of any support that was available to them to help them to access hospital appointments. The support is there, but they weren't aware of it, and that was a huge barrier to them accessing their healthcare appointments.
Other responses? Then I think Richard's our last question, isn't it?
Yep. I've taken away from today that we're pretty good on policy. We're not particularly good on signposting. There's a problem there, actually making people aware of the services. But I want to finish with the last question about asking about the inspection and monitoring of the system, because we've got a fragmented system. We've got a Health Improvement Scotland doing a certain amount of monitoring of health environment and also adult care in acute hospitals. We've got a proposal to have a peer review system now coming into primary care, but it doesn't involve patients. We've got the Care Inspectorate. We've got the Mental Welfare Commission. What do our witnesses today think about where we should be going in terms of actually monitoring? And if I can just give a specific example, it's 10 years since we passed legislation that said there should be, that every carer was entitled to an assessment, and yet they don't have an assessment, many of them. They don't know they should have an assessment. They don't get an assessment. And they don't have emergency care plans, which is fundamental to a sense of security and well-being. So that's an example of where we passed legislation, we think it's going to happen, it's not, but who monitors it? And who decides, look, this is not working in your area, your hospital, your community health and social care partnership now, who's going to inspect them? What do people think we should do?
Fiona, and then Derek, and then Pam.
Well, I think in the first instance we need to have a coordinated system of inspection of services, be they health or social care. I think the current system is very, very confusing for individuals if they actually want to make a complaint. It's not clear about who to go to, and I think particularly around mental health, complaints around mental health support. There's some really good examples of individuals being involved, and carers have been involved by the Care Inspectorate as lay inspectors for quite a long time. They aren't involved in the health inspections, but I think whatever system goes forward, I think individuals and carers, they need to be involved. It can't be something that's solely for health or social care professionals to assess quality for themselves, because certainly from our research, carers are very concerned about the quality of support that's available. It's a key reason that individuals turn down support, for example, a break from caring, because they're not confident of the quality of the service that's there. And then they find that when they do have a problem, it's so difficult to get a complaint through the system. And I think there was some discussion about what the steps for complaints might be in the future, and for perhaps a bigger role for the Public Services Ombudsman, in the same way that they can assess professional judgment in relation to health. They don't have that same role within social care, and so carers and people who have problems with services find themselves have a real barrier. So I think there's some, and I think integration gives us a really good opportunity to try and have an integrated system of inspection, an integrated system that monitors the national outcomes, because if there's no point in having national outcomes if we don't monitor what's happening with them and then act if things aren't moving properly in the right direction.
Eric, and then Pam.
Well, very quickly, I can echo exactly what Fiona said, as the two different bodies and the two different sets of standards of inspection potentially being a barrier to integration and achievement of the outcomes that have been established or being established as part of the process of the Public Bodies Bill. But funnily enough, both Healthcare Improvement Scotland and the Care Inspectorate are going to be, over the course of this year, reviewing their respective care standards, at least as far as they affect older people. The Care Inspector is talking about the new National Care Standards being simpler, easier to understand, and that will encourage, hopefully, users of services to then become advocates in their own cause. If it's easier for them to understand what their expectations are and what their rights are, then they, in many senses, will become their own inspectors. But also the standards of care in what was acute care, now hospitals, in Healthcare Improvement Scotland. If both of these can be simpler, can be rights-based, and can encourage a culture in which people are more aware of and more willing to pursue their own rights, then that takes away from, having to have an army of inspectors looking at every dot and comma of every piece of practice, but empowers people to actually become partners in their own care and treatment.
Again, very much echo what's already been said. I think if we can include service users and disabled people specifically in this inspection regime, I think it'll be really important. But I also think we need to be focusing sometimes our inspection at a different sort of level. So it's important to obviously inspect frontline services, because I think that's essential. We don't want to let that slip. But we also need to be inspecting the delivery or implementation of policy and rhetoric. I think that's really important, and it's come across today as well. So I think that is a key focus, or should be a key focus for inspection regulation going forward. And then just to a little point on complaints and review, we very much think that the system as it stands, particularly around social care, is unclear, disjointed, and in many cases quite daunting. Part of that is because there isn't always easy access to advocacy, because very much it's either impairment-based focused or geographical, so there's gaps in provision for advocacy, which makes it difficult to pursue a complaints process, and also because it's so different in terms of the health service as well as the social care service. So we would like to see a much more joined up system that considered and had disabled people and service users integral to that process. We don't know yet that giving the Ombudsman more powers will quite be enough to do that. We know that, for example, the variation across local authorities in terms of provision of social care standards and social care eligibility criteria, charging for it, etc., is so massive that actually it could be quite difficult for the Ombudsman to be able to consider that. And so we think that there needs to be further work done in terms of the complaints review process, and we hope that disabled people and their organisations will be integral to that going forward.
As far as the idea of migration and how this impacts on accessing health, when I worked with setting up a national structure for the adaptation of international health workers, now in Scotland, health professionals who came here, one of the things was that nobody knew, and I certainly didn't until I started the job, how all the different systems that exist about regulation, about language, about working in practice in the NHS, all these different systems, how they all interacted. And actually the work became how to work out what needed to be done within the system. And I think, I'm not sure about monitoring it as such, but before that, nearly there's a piece of how the current system works and creates problems for access for migrants. A piece of work just to work out how it actually works, and then from that, I mean, I don't know whether existing systems already are sufficient around monitoring as they would impact, but at the minute we don't quite know how the system exists and prevents access or reduces access.
Cluttered and confused. I've not got any other questions. I think we've run out of time anyway, but can I thank you all very much on the committee's behalf for the time that you've given us here this morning, and of course the written evidence that we have received. I think it was very useful hearing from voices that we haven't heard from in the past, and all of this was very useful as well. And hopefully we'll be able to use all of that usefully in our considerations as we look at this very broad issue of inequalities and how we can make a difference. Thank you all very much for your time this morning. I suspend the committee at this point before we go into private session.